Excellent. And I would advise you to go to someone else next time you have a question. I'm going to talk about clinical testing is insufficient for diagnosis of brain death. Um, um, I have no relevant disclosure except for the fact that I strongly believe in the concept of death of the brain. And I think that death of the brain is real. The brain dies when there is cerebral circulatory arrest. Cerebral circulatory arrest results as a consequence of refractory intracranial hypertension. This is an example from yesterday. If you look at the date here, where the mean arterial blood pressure is barely above the intracranial pressure. Minutes later, the ICP was already exceeding the map. And therefore, diagnosis of brain death is done in the presence of cerebral circulatory arrest. Uh, Cerebral circulatory arrest it means that in the acute setting, in my mind, there cannot be a confident declaration of irreversibility without sustained cerebral circulatory arrest. And this is relevant to the intellectual process necessary for brain death declaration. This is another example where the mean arterial blood pressure is exactly the same as the intracranial pressure. And that means that the perfusion to the brain has stopped, as proven here by indirect blood flow estimation. I want to present a couple of cases to illustrate some of the points here. The first one is a 54-year-old male, post-cardiac arrest. The patient remained comatose after return of spontaneous circulation, and a CT scan was done shortly after ROSC. The CT scan, as you see here, shows already diffuse cerebral edema, lack of differentiation between the gray and white matter, widespread hypodensities in the cortex bilaterally, absence of most of the cerebrospinal fluid spaces except for the ventricles, pseudo-subarachnoid hemorrhage, in summary, diffuse cerebral edema, diffuse ongoing cerebral infarctions. The patient was not exposed to hypothermia, and in neurological exam performed 3 days later demonstrated the absence of brainstem reflexes, and the patient was not breathing above the ventilator set rate. When moving the arms, the patient had a very strong head turning that was interpreted as a spinal reflex. It has been described in the literature many times, and it seems that the lateral head rotation arises primarily from activity of the spinal portion of the accessory nerve, the cranial nerve 11, because the motor nuclei is mostly located at the first few segments of the cervical spinal cord. However, a transcranial Doppler performed showed robust flow at the carotid siphon bilaterally, although the patient had isolated systolic spikes in the posterior circulation. As you probably know, isolated systolic spikes are a pathognomonic finding of circulatory arrest in the insonated area. However, anterior circulation bilaterally showed a decent amount of cerebral blood flow by transcranial Doppler. So the question here, the apnea test was not performed, and the question here, should the apnea test be performed in a patient who fulfills the clinical exam and criteria for brain death and has a clear defined cause? So the cause of the devastating and irreversible brain injury is very clear. The neurological exam is compatible with brain death, and the movement that the patient exhibits are considered to be spinally mediated. However, the ancillary test demonstrated the presence of remaining intracranial blood flow. Should we proceed with apnea test, or should we continue with the process of declaring this patient dead? In my opinion, the answer should be no. And some people would argue that why is a transcranial Doppler necessary instead of going straight to the apnea test? And in this case, I would say that in my practice for the last many, many years, I carry personally the transcranial Doppler every time that I go to examine a patient who may be progressing or may be brain dead. And I always perform a transcranial Doppler before the apnea test. Some people would say that exposing this patient with some residual intracranial blood flow to an apnea test where the PCO2 goes up and the patient will have, as a result of that, probably some degree of vasodilation and increase intracranial pressure, can lead to eventually cerebral circulatory arrest and brain death induced by the hypercapnia and acidosis secondary to the apnea test itself. I'm going to present a different case now. Case number 2. This is a 60-year-old male, post-cardiac arrest. The patient underwent hypothermia for the management of hypoxic ischemic brain injury. The patient was comatose from the beginning after ROSC. An examination performed many days later demonstrated deep coma and absence of all brainstem reflexes. This is the first CT scan done within hours after returns of spontaneous circulation. There is some degree of cerebral edema already, but as you can see here, the peripontine and peri-midbrain systems are still open, ventricles are still open, and the CSF spaces are still open. A CT scan done 5 days later, while the patient was comatose and no brainstem reflexes, shows this. The patient had developed predominantly hypoxic ischemic brain damage diffusely, but more importantly in the cerebellum. And as a consequence, there was some obstruction of the CSF pathways, developing acute obstructive hydrocephalus. In addition to that, the patient had lost all the differentiation between the gray and white matter, and now the cerebral edema was widespread. A transcranial Doppler was performed in this patient, and as you can see here, there's a decent flow bilateral anterior circulation as well as in the posterior circulation. So similar circumstances, similar question, a patient 5 days after arrest, after rewarming the hypothermia, that has a deep coma, no brainstem reflexes, and a catastrophic brain injury demonstrated by CT scan. Should we proceed with an apnea test? Or in cases like this, where a flow study is done, we should wait until the patient eventually progresses diffuse cerebral edema and potentially leading to refractory intracranial hypertension and cerebral circulatory arrest. So the determination of cerebral circulatory arrest prior to performing an apnea test may sometimes cause delays in the declaration of brain death. And there are many potential cons that go against or argue against performing a cerebral blood flow or study prior to an apnea test. And many of them are, as we heard before, the gold standard as understood currently in the US is based on the clinical exam of the patient. In addition to that, trying to do flow studies has some potential problems, right? Patients may not have, or at least easy access to flow studies. Delays may cause death while waiting. Patients like I showed before, where some residual flow is still in there, those patients are likely to progress to cerebral circulatory arrest. It's a matter of time most of the times. But while waiting until the patient progresses so we can declare or pronounce brain death, some of these patients may go to a cardiac arrest. This may cause some further stress to the family, and some of them may tend to withdraw life-sustaining therapies even before brain death is declared. The delay may also compromise the quality of the transplanted organs. Many people argue about that, and potentially preclude the diagnosis of brain death as patients may become unstable from either a hemodynamic or respiratory standpoint, and which may preclude the diagnosis of brain death. Because, for instance, a patient may become extremely hypoxemic and an apnea test cannot be performed. However, that has not been necessarily our experience. We are 4 neurointensivists at the University of Chicago. All adult patients in which brain death is suspected, we consult on those patients even if they are not our primary patients, and we are the ones pronouncing brain death in all the cases. In the last 3 years, no one patient that was pronounced brain dead here at this institution and authorized organ donation arrested before going to the operating room. We don't have data regarding organ survivals in the recipients. However, there's growing body of literature showing benefit from long duration brain death. Actually, there's some evidence that there's an active and probably very severe inflammatory process that happens around the time of brain death. And after the patient goes into cerebral circulatory arrest, some of these significant inflammatory markers go down, and some patients become way more stable after that. Some patients, as opposed to general beliefs, became, as I said, more stable with time. And sometimes this gives us time for improving oxygenation, either because the inflammation subsides or we maneuver the lungs and optimize the mechanical ventilation, putting them under a better gas exchange situation so we can perform an apnea test in the upcoming hours. And also the families that opted for withdrawal life-sustaining therapies while waiting for the patient to be pronounced dead, those families were offered the possibility of donation after cardiac death. There's another point that has been mentioned before, that is the neuroendocrine preservation dilemma in brain death. And the story is that many of the patients pronounced brain dead still have the ability, theoretically, to have an adequate water metabolism, and they don't develop diabetes insipidus. And some of them may not become immediately hypotensive due to adrenal insufficiency or thyroid insufficiency. As it was mentioned before, there are anatomical reasons by which the posterior part of the hypophysis at least, and probably the hypophyseal trunk, and also some parts of the hypothalamus maybe have some preserved circulation due to the extradural origin of the arteries that supplies those territories. For instance, the inferior hypophyseal artery arising from the proximal part of the cavernous sinus of the internal carotid artery. Or, for instance, the capsular artery that is also arising from the cavernous sinus that supplies the outer layer of the anterior lobe of the pituitary lobe as opposed to the posterior lobe, and has penetrating branches. They enter deeper into the anterior lobe in most of the glands. So in summary, both the inferior hypophyseal artery and the capsular artery, that are both extradural branches, supply the neurohypophysis, that is the one that deals with the water metabolism through the antidiuretic hormone, the stalk, part of the hypothalamus, and part of the adenohypophysis as well. And persistent flow, and therefore those patients may have persistent flow despite cerebral circulatory arrest. In addition, the hypophysis is spared of some of the deleterious effects of the intracranial hypertension due to their particular anatomical partial compartmentalization of the sella turcica by the diaphragma cella here, that is somewhat protects the hypophysis from the downward pressure of the refractory intracranial hypertension. In summary, from a functional and almost anatomical standpoint, the hypophysis, or part of it at least, behaves as an extradural organ many times. This is our own experience here, unpublished data, but we looked at 31 brain dead patients quite a few years ago, and we looked at the presence of diabetes insipidus and hypothermia at the time of diagnosis of brain death or shortly after, within the next few hours. Interestingly, all these patients had CT scan of the brain done, and the majority of them confirmed intracranial circulatory arrest by some ancillary tests, most commonly transcranial Doppler. And what we saw is that this is a typo here, should say 29, I'm sorry, but when intracranial circulatory arrest was documented in these patients, 96% of them, almost 97% of them, had diabetes insipidus. And when intracranial circulatory arrest was confirmed as well, 93% of those patients were hypothermic or had been hypothermic at some point right prior to the diagnosis of brain death or immediately after. Going back to one of the papers that was mentioned a couple of times today by Dr. Jim Bernat, about the inconsistencies between the criteria and the tests for brain death. I'm not going to talk about this too much because it was already discussed previously. But what Dr. Bernard suggests as a possible solutions to address the mismatch between the whole brain criteria of death and the brain death tests is that there are two potential solutions. We must either loosen the whole brain criteria of death, or we might tighten the brain death tests. And I'm going to emphasize the second part of it. As Dr. Bernard says, a second solution is to tighten the brain death test. If, as we suspect, it is demonstrated that most reported cases of residual brain function in brain dead patients result from the absence of intervening period of complete intracranial circulatory cessation, one option would be to require an ancillary test proving the cessation of intracranial blood flow. Although adding this requirement probably would eliminate most of the cases of mismatch between the whole brain criteria of death and brain death tests, obviously it would also reduce the number of brain death determination and consequent organ donation. Because no ancillary tests are free of false positive determinations, some authors have rejected this solution. And then he goes on to say that until then, and to uphold the standard of clinical certainty, we advocate proving the whole brain criteria of death by showing the absence of intracranial blood flow, concept that I fully adhere to. I'm going to now talk about two special scenarios. One is devastating irreversible brainstem injury, and the second is hypoxic ischemic brain injury. The first of them is a patient with a large pontine hemorrhage with invasion into the fourth ventricle. And this patient presented in deep coma, absent brainstem reflexes, and an apnea test was performed with a PCO2 of 70 millimeter of mercury. Patient didn't have any spontaneous respiratory movement. So the question is patient dead? And the answer probably should be possible, but not definitely. The way this particular patient could progress to brain death is the following. In the presence of a brainstem hemorrhage, there may be extreme progression, but in the absence of hydrocephalus, this patient, due to the massive brainstem destruction, the patient may show brainstem areflexia. However, this is a localized brainstem injury, and there's no hemispheric injury concomitantly. So this patient may look dead, but it's not dead in fact. However, if the patient has continuous progression with hydrocephalus due to obstruction of the CSF pathways, like this patient is having incipient hydrocephalus, if the hydrocephalus is left untreated, as would happen very commonly due to the severe bad prognosis of the patient, there will be a moment where the intracranial pressure will be at least equal to the mean arterial pressure. And at that time, intracranial cerebral circulatory arrest will ensue. And at that point is when the circulation ceases, when the patient becomes dead. So does it matter if this were to be about prognosis? Probably not, but it's not, since it is the actual occurrence of death. Yes, it does matter. That was in the past. Currently, we try to only call patients dead when they are dead, because this is the common denominator where they go after that. A couple of years ago, authors presented a few cases of brainstem damage, and all those patients eventually with successive brain flow studies progressed to circulatory arrest due to untreated obstructive hydrocephalus. And 2 years ago, Alex Manara, Panos Varela, and Ilko Wilkits wrote this editorial in Journal of Neurosurgical Anesthesiology, and in where they say that the authors wonder whether it is necessary to await the loss of any persisting supratentorial cerebral blood flow before diagnosing brain death in patients with an isolated brainstem lesion. Demonstrating the eventual loss of supratentorial blood flow in these rare cases may increase the confidence of some physicians in making the diagnosis. Moreover, if all patients with an isolated brainstem lesion are shown to lose supratentorial blood flow over time, like they did in these patients, performing such a test may no longer be necessary. I would argue against this because I believe that demonstrated the progression to intracranial circulatory arrest in these patients is necessary. And not only that, declaration of death in these patients should happen at the time that the patient undergoes intracranial cerebral circulatory arrest and not any time before that. The last case I'm going to present here is a case of a hypoxic ischemic brain injury, 51-year-old female, sudden cardiac arrest. ROSC was obtained. The patient presents comatose after the cardiac arrest due to cardiac problems that are treated. 12 hours later, the vital signs are good. The patient is on the ventilator. However, the patient is deeply comatose. No brainstem reflexes, and the patient is not breathing above the ventilator set rate. The CT scan is this, and the question is, should this patient or can this patient be dead by neurological criteria? And the answer should be clearly no. This CT scan is pretty much normal or almost normal. However, a completely different scenario would be this one, where a CT scan shows diffuse cerebral infarction, massive amount of brain swelling, disappearance of all the CSF spaces, massive downward transtentorial herniation. And therefore, the images become a fundamental part in the diagnosis of brain death. I'm going to spend a couple of minutes just emphasizing this point. The evidence-based guideline, the American Academy of Neurology for determination of brain death that were talked or shown before in this conference, they were published in 2010. They barely mention neuroimages, and they say that the clinical evaluation of prerequisites, the physician must establish irreversible and proximate cause of coma, and the cause of coma can usually be established by history examination, neuroimaging, and lab tests. And that's pretty much the only part where they mention neuroimaging. Recently, a consensus practice recommendations for pediatric and adult brain death or brain death or death by neurological criteria were open for comments from the public. These guidelines are not published yet, but I had access to them because they were publicly available for a period of time. And what they mention, things look much better now, that neuroimaging can assist when identifying the mechanism of brain injury. They also say that in patients with hypoxic ischemic brain injury, there may not be visible changes on initial neuroimaging studies to support the diagnosis of brain death, and therefore follow-up neuroimaging is advisable. Neuroimage that has been performed after sufficient time has elapsed from the onset of the brain injury should show findings consistent with a mechanism of catastrophic injury known to lead to brain death. This is much better than neuroimages to justify coma. Coma is relatively easy to justify, and that was proposed back then in 2010. Now, the idea is that the neuroimages should be consistent with a mechanism of catastrophic injury that is known to lead to brain death. And I think that that's very important. If ancillary testing is needed for diagnosis of brain death, before proceeding to an ancillary test, the brain death neurological examination and the apnea test still need to be performed to the fullest extent possible. This is somewhat different than the first two cases I presented earlier a few minutes ago, where in my personal practice, I do a transcranial Doppler, very easy at bedside, able to get windows in the majority, sonographic windows in the majority of the patients. And I know within minutes if the patient has some preserved circulation or not. The caveat here is that if you find circulation intracranially, performing an apnea test, as I mentioned before, may induce further intracranial hypertension and more compromise of the intracranial perfusion. To avoid declaring brain death in patients with primary posterior fossa pathology and retain supratentorial function, clinicians should ensure that the posterior fossa process has also led to catastrophic supratentorial injury as demonstrated on a conventional neuroimaging study. Again, this is about the patient with brainstem injury that I show you, and I think that this is a fundamental and very important statement. The World Brain Death Project published last year that was also mentioned before also adds some interesting information here. It is suggested that if an assessment of brain death is being made in a region that equates whole brain death with brain death in the setting of an isolated brainstem lesion or posterior circulation, vascular lesion, ancillary testing should be performed. And this is the first time or where there's a clear suggestion of performing an ancillary testing when there's an isolated brainstem injury. In this circumstance, suggested that brain death should not be diagnosed until supratentorial and infratentorial blood flow is lost. And I believe that this is a very important statement. It is suggested that prior to making a determination of brain death, there be neuroimaging evidence of intracranial hypertension, severe cerebral edema, and herniation, or intracranial pressure measurement that equals or exceeds the mean arterial blood pressure, as I mentioned, or as I showed in a couple of cases at the beginning of the conversation. So again, emphasizing that the neuroimage must not only show or potential cause of coma, but also either devastating irreversible brain injury that is known to lead to brain death or evidence of intracranial hypertension, probably here determined as cerebral edema and herniation, okay? It is suggested that in the absence of herniation or neuroimaging, caution be taken when considering evaluation for brain death. And this is similar to the scan I showed in case number 3, patient after a cardiac arrest who has an exam that seems to be compatible with brain death. Apnea test has not been performed yet, but CT scan doesn't show signs of intracranial hypertension, cerebral edema, or herniation. The last 2 minutes, or the last minute I'm going to use for my conversation today is in regards to the cerebral circulatory arrest and the apnea test. As you all know, the goal of the apnea test is to demonstrate the absence of spontaneous respiratory movements that are generally due to the lack of respiratory centers function, even under maximal stimulation. Maximal stimulation is provided by allowing the CO2 to rise and the pH to decrease in the CSF that surrounds the ventral medulla, as well as intracellularly in the same area of the lower brainstem where the respiratory centers are located. In general, this rise in the CO2 and drop in the pH is achieved by disconnecting the patient from the ventilator. In the presence of apnea, if the patient is apneic, the CO2 cannot be eliminated and therefore accumulates in the blood, causing an acute respiratory acidosis, high PCO2, low pH. For these changes to influence the CSF and the brain intracellular status, there must be preservation of cerebral blood flow so the blood can get to the brain and the transmission, the changes in the CO2, the changes in the pH can go through the blood-brain barrier and elicit changes in the cerebrospinal fluid. But in patients who are in cerebral circulatory arrest, none of the systemic variations translate or will translate into intracranial changes. The dead brainstem will not function regardless of the systemic PCO2 and or the pH. As a result, the mechanistic concept of maximal respiratory center stimulation used in this model is probably flawed. Apnea testing, as currently understood, applies only when there's preservation of cerebral blood flow, and it's unclear until what level of hypoperfusion these changes happen between the blood, the CSF, and intracellular in the brainstem. For patients who are in cerebral circulatory arrest, we probably need to reformulate the concept applied to this maneuver. In summary, I can say that the death of the brain is a real entity. The cerebral circulatory arrest is the one that assures irreversibility of the process. The brain death diagnosis is a clinical radiological diagnosis at the very least, and I would not say that it's a clinical diagnosis eminently. It is a clinical and radiological at the very least. And there should be strong consideration for flow assessment. And the current concept of maximal stimulation of the respiratory centers in cerebral circulatory arrest probably doesn't apply. Thank you very much.
Thank you, Fernando. We can open the platform for questions. In order to respect everybody's time, we're going to keep a hard stop at 4:35. And I want to have Bob Trug ask the first question, and then Ariane can reply.
Okay, well, thank you very much. And Ariane, thanks for the very nice talk. I thought that the discussion of sort of the history of gold standards was very interesting. That's what I'd like to ask you about, is sort of what gold standard means here. It seems to me that in order to talk about a test being a gold standard for making a diagnosis, we need to know what it is we are trying to diagnose. So for example, we would say a blood culture is a gold standard for making the diagnosis of bacteremia. We have a clear target as to what it is we're trying to diagnose. But for brain death, what is it that we're trying to diagnose here? It seems to me that the gold standard would be different if maybe we're talking about the death of all cells in the brain as a definition versus the absence of all function, or the absence of all critical function, or the loss of, the irreversible loss of consciousness. Each of those definitions would lead to a different gold standard. So since we don't have agreement about that, what is it that you mean when you talk about a gold standard?
Thanks, Bob. I think first, obviously, it's important to recognize that there are varying philosophical concepts of what brain death is, and that's been evident throughout the day today, but also obviously throughout the literature in terms of what we can, how we can define the concept of death by neurologic criteria. Is it loss of higher brain function? Is it loss of whole brain function? Is it loss of brainstem function? Is there just nothing? Do we not actually have a concept of brain death? Is that not something? And obviously there's philosophical disagreement with respect to that. You can see, looking at varying protocols around the world. You can see my screen now?
Yes.
Yes, okay. So in terms of from the philosophical perspective with respect to how to define death by neurologic criteria, protocols around the world use various terminology in terms of the extent of damage, the activities and functions that need to be lost to declare death by neurologic criteria, and the anatomical regions that are affected in death by neurologic criteria. And I think that obviously emphasizes the fact that perhaps we don't have a gold standard with respect to the philosophy of death by neurologic criteria. However, in terms of the practice of how to go about declaring death by neurologic criteria, we actually do have consensus with respect to that, in so much as from a clinical perspective, it is necessary to evaluate the patient for evidence of coma, absence of brainstem reflexes, and inability to breathe spontaneously. And that from a clinical perspective, in terms of the practicality of declaring brain death, we do not require ancillary testing. We do not require any particular neuroimaging findings. As Fernando rightly pointed out in the World Brain Death Project and in the updated draft of guidelines from the AAN that should hopefully come out later this year or early next year, we did actually introduce the concept that there should be neuroimaging findings that shows evidence of injury to the brain. But that has not been there in the past, and so that has not been included universally around the world. I'll also note that in terms of the analogy with respect to bacteremia, that's actually a flawed analogy as well, on account of the fact that a positive blood culture isn't definitively evidence of bacteremia. In fact, that could be evidence of a contaminant, and so you have to imply some semblance of judgment to decide whether or not what you actually see is bacteremia. And that gets into all sorts of problems with respect to other studies related to when a patient is indeed bacteremic, like when they've developed a CLABSI. And I think that's just sort of another different philosophical issue here.
Yeah, good point on the bacteremia example. But it does seem that you're not really talking about a gold standard. What you're talking about is consensus. You're talking about that all neurologists agree that they're going to diagnose brain death in the same way, but they don't have agreement about what brain death actually means. They don't agree whether it's the loss of all brain function, or if it's the loss of consciousness or irreversible apneic unconsciousness. And without that, the requisite tests would necessarily be different.
Yeah, so actually, as I noted in terms of what the definition of a gold standard is, and that's why, as you mentioned, I went through so in such a detailed fashion as to what gold standard actually means before trying to identify what the gold standard was. Both in the literature and even on the common man's version of the literature, Wikipedia, a gold standard is defined as consensus with regards to the benchmark for diagnosis or prognosis or management. Relatedly, I think it's worth noting that, as has been brought up already, that there is some difference between what is the legal criteria for death by neurologic criteria, the legal stipulations for how to describe death by neurologic criteria in comparison to the medical standards. And I think that many of the people on this panel have noted that that discord is problematic. When the original language of the UDDA was being written, there were multiple different variations as to how to define loss of function, how to define death by neurologic criteria, whether or not it should be using the phrase loss of function of the brain as a whole, loss of function of the whole brain, including the brain stem, whether it should include specific tests to be able to make that evaluation, whether it should refer to specific medical standards. And ultimately, obviously what was selected was loss of all functions of the brain as a whole, the whole brain, including the brain stem, which has its problems associated with that.
Okay, thank you.
Ari, go ahead.
I just want to comment on that. I agree with what Dr. Trog says, is you can't have a gold standard to diagnose something unless you know what that something is. And I've experienced in debates before that people, medical people, seem to dismiss philosophy. I'm not a philosopher, so meaning I don't have a degree in philosophy, but I've taken several philosophy courses and read much of the literature in philosophy about death. And I would argue that part of philosophy is to subject assertions to critical scrutiny, clarifying exactly what the assertion is saying, its implications, and thus its direct plausibility. So if the goal is to ensure clarity, logical consistency, and rational argumentation in order to arrive at reasoned conclusions, I would argue that philosophy is how to do that.
So first, I in no way want to seem dismissive of philosophers or philosophy as a whole. I fully acknowledged, as way of disclosure, I have no background in philosophy. I have no formal training in philosophy, and I'm not equipped to make philosophical arguments as many of the people here are. However, I can speak towards the practicality of determination of death by neurologic criteria in terms of how that is conducted and what are the medical standards at this point in time.
Fernando.
Thank you, Christos. I have a question for Dr. Trog. In your daily practice, when you face a patient that may be progressing to brain dead or maybe brain dead, how do you proceed? And what is the things that you explain to the family?
Oh my goodness, it's a very broad question. Could you narrow it down a little bit? Like, I mean, we're obviously talking with the family regularly.
I'm mostly interested, do you follow what is written in all the guidelines in respect to the diagnostic process? And when you face the family, do you explain your position about the legal fiction or not necessarily?
I see what you mean. Thank you. Yes. When I meet with a family where I've made the diagnosis of brain death, I say that we've done testing, which we believe is highly reliable for showing that your child is never going to regain consciousness and never going to be able to breathe spontaneously. And in the state of Massachusetts, this means that your child is dead in a legal sense, and we will be filling out the death certificate.
Thank you.
I wanted to ask something. Oh, sorry, Fernando, go ahead.
No, Christos, please, and then I'll follow up with a question. No worries.
No, I just wanted to bring up the point and hear thoughts about false positivity, and that has come up in the chat and Q&A as well. The idea that if we do accept that it's going to be a clinical determination about death, if it's reasonable to require a 0% false positive rate. I mean, do we know what is the false positive rate in the case of cardiorespiratory determination? So I just want to hear your thoughts about this issue of false positivity, and if it's fair to what should be an appropriate rate. Should it really be 0?
I'll just chime in. We do know the reliability of checking loss of circulation. What we don't know is the reliability of our flow studies for brain death, because I showed you that there are several cases of false positive, and all the other positives had care withdrawn, and so we don't know if there's a return of function. So I don't think the question is how rare is it, because we don't even know that answer. As long as we show that it's not 100%, and there are definite clear cases of false positives, I think that's enough.
I'll add to that 2 comments. First, which is that obviously there's a bias with respect to what appears in the literature. So people are not necessarily inclined to publish cases where they've made any error in brain death determination, or perhaps they perceive that they've made an error in brain death determination. So we really, we don't have the systematic way to keep track of these cases and have a better understanding as to whether or not there's any spontaneous recovery of function in these patients. And as was pointed out, if we are discontinuing support for these patients, then obviously we lose patients therein, because there are not large bodies of patients that are being sustained for protracted periods of time. Additionally, it's important to recognize that there's a lot of nuances associated with conducting the evaluation in terms of things to rule out beforehand, medications, and other conflicting things like metabolic derangements, hypothermia, et cetera. And when you're not the person who's actually conducting the evaluation and you're only hearing about it from someone else, and you're not the person who's evaluating the patient and performing the assessment yourself, there are a lot of nuances that make it challenging for you to really fully be able to identify whether or not somebody actually does indeed have some recovery of function or not.
Fernando, you want to finish your thoughts?
No. I think that they were included in the prior conversation. Thank you.
Okay. Tadeusz, you want to make a comment?
I guess I want to push Bob Trug's point, which is to push Ariane, which is, right, everybody agrees that these tests are the right tests, right? And it's a consensus, but I guess tests are to measure something, right? And I guess you have to have some sense of what it is that the tests are measuring. And that seems troubling, right? That's not articulated. I don't know, I guess maybe that's enough of a question.
So I think when you're thinking about the language, obviously associated with what are you testing and what does the test show, there needs to be some semblance of cyclical logic therein, similar to the analogy related to bacteremia. What is bacteremia? Bacteremia is the presence of bacteria in the blood. If we find that there's bacteria in the blood, what does that tell us? The patient is bacteremic. So there is cyclical logic inherent in that argument. And so I think that, yes, I agree that obviously on a philosophical perspective, there's many different versions of what we can define death by or how we can define death by neurologic criteria. But at the end of the day, if we have certain criteria that we say, these are the standards for declaration of death by neurologic criteria, meeting those standards means the patient is dead by neurologic criteria.
Let me just push, because the one thing I guess every single person on the call gathered from today is that this, unlike bacteremia, this is value laden, right? This is what is human death? What is death is not a purely objective scientific thing. It's value laden. And that, I think, is what breaks down that analogy between the cyclical nature of defining bacteria and this, right? So when clinicians say this test, these are the tests, therefore it's death, that's not a scientific, they're doing two things. It's a scientific judgment, but they're also making the value-laden judgment when they equate the two.
So I don't actually feel like the fact that, I mean, I agree for sure that there is a variety of different value-laden issues pertaining to declaration of death by neurologic criteria or declaration of death in general, but I don't actually think that to me, the philosophical views as to whether we're talking about loss of all function of the entire brain or we're defining death as a irreversible coma, to me, the specific terminology used therein, I don't consider to be impacting the value associated with it. To me, that's a much bigger question in terms of, do you believe from your value perspective that a person can be dead if their brain is not working, just sort of very broadly, not in getting down in sort of the nuanced language therein. If you believe that, then you can conceptually believe in death by neurologic criteria. If you believe that ongoing support, when physiologic support is being provided to the rest of the body and the patient is able to maintain their blood pressure with the support of the ventilator and other medications, that means that they're still alive, then from your value-laden perspective, you don't believe in death by neurologic criteria. But to me, the nuances of this specific language, and I realize that this is not the perspective of philosophers who spend a lot of time thinking about the nuances of language, but to me, that doesn't make a difference therein.
It does seem, though, that there is a scientific part as well as a value-laden part. So the scientific part seems to me that the AAA guidelines are meant to demonstrate a state of irreversible apneic unconsciousness. That is what they're focused on. And you know, one of my points was we should say that. And then the value-laden part is, does that mean that we can treat you as being dead? Are you as good as dead when you are in a state of irreversible apneic unconsciousness? And that is where I think we would get into the philosophy. But I think that there's room for improvement on both parts. I think that the AAN should be more straightforward about what the diagnosis actually signifies. And then secondarily, we need our philosophers to opine about the relationship of that scientific diagnosis to the, everlasting issue of what does it mean to be alive or dead.
I would argue against the use of the term as good as dead in so much as we should have something that we're defining as dead or not dead. There shouldn't be somewhere in between where we say you're as good as dead. Either you meet the criteria for death or you don't.
Dr. Johnson?
I actually just wanted to bring up a question that came up in the Q&A from Darren, because I think it applies to all of the speakers here and is really interesting. So given the concerns about the accuracy of the clinical exam and also some ancillary testing, why are we pushing to have a single exam? Why are we pushing for a clinical exam or making a clinical exam better, given the stakes here, given the potential for the public to lose confidence in what it is that we are actually diagnosing here? Why not as many tests as we can to confirm what we're looking for? Why think that there is any gold standard here other than doing everything we possibly can to confirm the diagnosis?
I'll field that. Thanks for bringing that question up, Sid, and thanks for asking that, Darren. I saw that in the chat and thought that was a very good question. In writing the updated guidelines from the AAN, which have not been finalized at this point in time, as was mentioned by, I believe, Fernando's who brought them up, they have just recently been under review for public comment, and now there's going to be a third round of voting before the guidelines are now finalized as guidelines, so there's still certainly opportunity for them to change. But at present, and what was produced for the public review, was that at this juncture, the proposal is to have a requirement that there be 2 evaluations prior to declaring death by neurologic criteria. The 1995 guidelines did indeed also require 2 evaluations to declare death by neurologic criteria. Subsequent publications demonstrated that if the first evaluation was consistent with death by neurologic criteria, then the second evaluation never negated the first evaluation, which led to the question as to whether or not 2 were really needed. And so as a result, in the 2010 adult guidelines, this was reduced down to 1 test, 1 evaluation. In the pediatric community, always more than 1 evaluation has been required, and that's been part of what brought forth the question amongst the adult community to bring this together, is to allow for there being the same number of evaluations between both populations.
Can I ask a question, Christos?
Please.
For Ariane, I understand that you're trying to come up with a uniform guideline for adults and pediatric patients, but having only 1 evaluation for the last so many years, and some literature saying that, as you said, that the second doesn't change anything, and it's a recent paper by Panos Varelas again a couple of months ago, or even less, showing kind of the same evidence. Why are you changing the rules now?
Yeah, so I would say this has definitely been a topic of hot debate. And, there's the perspective of, as Darren brought forth, that, maybe we should have more than 1 exam so that we can make sure that we're really confirming the first person findings and feel extra certain about what we're doing. But then there's the perspective, as you mentioned, that if the second exam has notoriously shown us to be confirmatory of the first exam, why are we requiring 2 exams? Also, against the view of Darren, is the question of, well, how do we say that 2 exams makes us more confident? Why aren't we doing 3? Why aren't we doing 4? When do we say that we've done enough to make sure that we're doing the right thing? And I think that there are varying perspectives on that, as I said. And at present, we've landed on that there will be 2 exams required, but that could change after the 3rd round of voting.
But if we're doing the same exam multiple times rather than doing ancillary tests, we probably can expect to get very consistent results. So why aren't we requiring ancillary tests that might show something different?
I'm sorry.
Somebody wants to pick up Sid's question about.
I don't have an answer to that. I just think that without offending anybody, I think this is showing why clinicians cannot articulate a standard for diagnosing brain death because of several reasons. One is that we ignore philosophical discussion, which is to clarify what we're trying to say and what we're actually saying. And what I tried to show in my talk is that there's so many flaws with the clinical tests and confounders that there's some intractable confusion and debate because we haven't clarified what we're trying to say. In terms of the ancillary tests, then, for example, people say the EEG isn't enough, isn't an ancillary test, except for children, because it only looks at superficial cortical injury. But at the same time, if there is activity present, it shows that there's function. I showed you if there's theta and delta activity, the patient may be locked in. And when we look at blood flow studies, they simply are not adequate because there are the cases of it, even something as basic as breathing occurring when there's absent flow. And so I think that, I hate to say it, but the medical attempts to keep trying to come up with criteria that by consensus are accepted is irrelevant, because if we don't know what we're diagnosing, and if we don't acknowledge the flaws and the confounders, who cares if there's consensus? That's my point of view.
I'm not sure we don't know what we're diagnosing. I think that the pretty much the practitioners who see these patients and diagnose brain death, they know pretty well the diagnosis of brain death. And I think that all these things are complementary. And as long as you have rule out all the confounders and you have a very clear justification for someone progressing to brain death that include images, and as long as you complete a detailed exam with someone who knows how to do it, and you do an apnea test, and you may add the flow study there, I think we're very good, actually. And we are presenting here the exceptional cases that are measured in 1 or 2 or 3 cases reported, while there are hundreds of thousands of patients. And I understand someone is going to say this is a self-fulfilling prophecy. The truth of the matter is that for people who have been practicing and doing this for many years and pronounce patients brain dead for many years, I think that those people feel very confident with the way they practice medicine.
No, I agree they feel confident, but that's because we're confused about what we're doing. And I already showed you that the apnea test doesn't even diagnose what we think we're diagnosing. So I disagree with you. But
all right, we have to stop. This can go for a very long time. And I hope actually that, after the conference, we can come back to these questions and these points and further work on them. But I really want to thank you for such a long day stuck in front of a computer screen. And please come back tomorrow at 10 a.m. Central. Thank you, everyone. Goodbye.
Thank you, Christos.
Thank you, Christos.